Thank you.
Okay, so we then have time to talk before we go on to the discussion a little bit. We've got Ian Hall, who's going to talk to us about emerging disease analysis. Thank you.
Thank you. Yes, thank you to the organisers for inviting me, and thank you to all the previous speakers for covering a lot of the background material that I'm going to rely on, I think, as we move through this. Just to amplify Valerie's challenge there with a transmissible disease, you've also got the issue that the signal you're fitting to there's probably some sort of reporting bias as well, so you've got a sort of double whammy of trying to infer the infection, but also want to know the natural history of the disease as well as the reporting behaviour of the population, so it's challenging. So I am from the Public Health England, part of Health Protection Directorate within the Emergency Response Department. There won't be a test on this afterwards. Science and Technology Group, and I head up the modelling team within that group. The group's sort of reason for existence is sort of given here. I'm not going to read that out in detail, but you can reflect on that at your leisure. We are multidisciplinary by design, so we have 5 sort of scientific and technical groups. There's the medical entomology and zoonotic ecology group. They go out into the field, see what mosquitoes and ticks we have in the country that could cause vector-borne diseases for the UK. They also run a tick surveillance scheme and a mosquito surveillance scheme, and give risk communication on how to get ticks off you if you find it. So there's lots of information on the PHE website or Health Protection Agency website. These slides are old, so apologies for that. Should have updated that. We have a behavioural science team that look at public responses to emergencies, how you communicate with the public, and how you evaluate exercises. The Emergency Response Department has to do exercises to test the health responders to infectious disease aspects. There's also an OR aspect, so that's where we sort of interface with the behavioural science team, mostly sort of looking at curing theory, processing of people through decontamination tents and things, should there be a sort of chemical attack or what have you, and looking at the effectiveness of those. We have sort of a technical support team who house the GIS, the geographic information for the organisation, and also look after our clusters so we can run our models. And then there's the epidemiology and modelling team. So we have 2 core functions. We have a response function, giving real-time advice to infectious disease threats. We also have a preparedness function, so that is contingency planning, playing God with a scenario and basically looking at how a disease might propagate through a community. And I'll give 2 case studies of that sort of work in later slides. And we have this sort of virtuous circle, which is similar to previous speakers' SMART thing, I think. So yeah, it's all the same. So how are we set up? We have sort of 5 work packages in effect. So we have a reverse epidemiology work package that's developing statistical techniques that can use data to infer something about the outbreak. We have the contingency planning that's developing models so we can simulate an outbreak. They come together into a decision support, so that's our sort of interface with government, Department of Health, or our parent organisation, but also wider parts of government, often to a lay audience, not to a sort of technical audience. We'll then have sort of a work programme looking at improving the understanding. So we need to understand more about the eco-epidemiology of some of these diseases. How do people interact with the environment to get infected? When they are exposed to an agent, how does their body deal with that? And also, how do people mix? What's the drivers for disease transmission? As well as sort of infrastructural work package looking at quality assurance, which is probably the main thing there, trying to make sure our models are evidence-based. So looking at those methodological work packages, we need to make sure that the models can make best use of the data that is collected by outbreak control teams, because there's a lot of effort goes into collecting that data, swine flu or other outbreaks. There's been a recent VTech outbreak. That data is hard to collect from individuals, so we need to make sure we've got the best possible algorithms to use it. We need to make sure that there's an evidence base to decisions around whether we vaccinate people or whether we quarantine people, and we need to make sure that people understand the outputs we give them. So just sort of defining what we mean by reverse epidemiology, I mean by reverse epidemiology. The driver here really is it's a covert open air release. You can sort of nuance that a little bit, but that's sort of the motivating example of some infectious agent, non-transmissible infectious agent, like Legionnaire's disease is the one that we often have to deal with. You see cases in a community, and that's your first trigger. You haven't got any intelligence of a disease outbreak prior to that. And you start getting some sort of temporal and spatial information about those cases. So you need to work out possibly who's been exposed and who will require treatment, and where the source is as well. Now there's a challenge there because as the plume, if you've got an outdoor release, there's a plume, the population under that plume, it's nice and circular in this illustration, but it could be a messier shape, but that population is likely to grow exponentially. But the number of people affected, because the dose will probably go down as you go further away from the source, the number of people affected will diminish. You're looking for a needle in the haystack as you go further away from the source. And there's greater uncertainty, basically, in who might be infected. You also have sort of challenging process aspects around data. So looking at the timeline here, you'll see there'll be data capture, some initial situational awareness, meaning there's a trigger. You get epidemiology. That might be enough. You might be able to clearly say everyone got infected here, but it might be more complicated. So then if you've only got temporal information, you've only got the epidemic curve, you can only do certain analysis. You can only sort of use convolution analysis to analyse that. If you've got spatial data as well, you can start to do things more, slightly more clever things that take more computer power, but you have to have a model that sort of uses the data in a fluid and flexible way. So yeah, if you've only got hospitalisation data, say, then you have to remove from that the delay from someone becoming ill to going to hospital. You also have to remove from that the delay from being infected to becoming ill, to work out when people got infected. So there's a couple of distributions you have to knock off the epidemic curve, so to speak, to get back to some estimate of the source term. And there'll be censoring, because there will be cases still in the system that haven't yet developed symptoms, so you've got to allow for that. Apologies for the quality of that image, it's not rendered particularly well. If you start to get spatial information, then you can sort of impose a behaviour of this plume structure, relatively simple plume for anyone who's a fluid dynamicist. That's just a Gaussian puff model. It's quite simple. You can get much more complicated models than that, but you can start to infer some of the parameters about that from the epidemiological data that you see. And we've recently used NIH funding, NIHR funding even, to quality assure that model. So that's our sort of frontline business critical model. We had to sort of stress test that in a sense of making sure it was fit for purpose. So we ran a lot of simulations with different climatic variables, different locations, to see how the fitting worked. And underpinning this, the network, because we're using home and work location from the cases, the underpinning data is the commuter matrix from the census. So it's just using nighttime, daytime sort of fluxes. But that means, because a lot of people work in London, if the release is somewhere else in the country, there is a propensity for the model to predict a London release. It sort of sucks things up to London. And that's sort of an uncertainty we'll have to unravel as we're sort of dealing with any sort of situation in that regard. And so yeah, the NIH funding, the Health Protection Research Unit funding, has improved the model. We've got better documentation now and a detailed benchmark. So that has really helped helped us QA that tool. But we need to put in more realistic priors, and there's aspects there around the fitting, but there are also aspects around that assumption that the commuter matrix is good enough, and I'll come back to that later. This is a typical output. Don't get too hung up on the graphs on the your left-hand side. But the map there is the sort of probability that the source was in a particular zone. Now, when we were working through this with the SAGE, which is Scientific Advice for Government During Emergencies, they sort of came back and said that's not actually a very helpful image for us as policy people. Okay, it's great to know where the source is, but we really want to know where the people were infected. What is the hazard? And more than that, what is the health message? How do we actually turn that hazard inference into a health message? And so, working with partners, we have looked at this tool called Countermeasure Delivery Optimization Tool, CDOT, which delivers some clear advice. So if people were in the red zone at some point during the outbreak, then they should seek to get their countermeasures soon. So this is assuming sort of anthrax attack rather than something sort of easier to deal with like Legionnaires. But yeah, so there's the red zone, then there's an orange zone, so that's the 24 to 48 hour, and then a yellow zone. And you can sort of play around with that, and you can work with policy people to tune that with respect to public communication as well as government communication. And we're sort of tuning, we're looking at different methods under Health Protection Research Unit funding as well as FP7 funding to improve some of the fitting tools there. So looking at moving on to contingency planning. I'm just using here as a case study smallpox. This is work we did probably 5 or 6 years ago, so it's quite old hat really, but it's a useful case study of how we go about doing contingency planning and builds nicely on Valerie's earlier talk. So smallpox has a very sort of well-documented natural history and epidemiology associated with it. But it was eradicated in 1979. So why are we interested? Well, when they eradicated the disease, they didn't destroy it. They kept a couple of stock vials in Russia and in the US. There was a period where there was question marks about the security of those stockpiles. And so we needed to plan for a future outbreak of the disease. And we have a vaccine for smallpox. We can quarantine people. They've got a rash. It's quite symptomatically obvious, clinically obvious. We could impose social distancing measures. You could do a lot of things. And so we developed an SEIR model with interventions built in to look at that intervention policy with all the different interventions you could do. We used the metapopulation model, The question then is, what scale do we use? Because, okay, we don't believe nationally we're all homogeneously mixing, but is a county structure sufficient? That runs nice and fast, but it's still probably a bit of a stretch. Districts, better, or wards. Now, at the time we were doing the work, a ward model with 10,000 metapopulations was beyond us computationally, or a stretch for us computationally. It wasn't quite beyond us. So we compromised on districts, and again we used the commuter matrix to sort of move people around the country on a daily basis to drive the disease importation. And you can play God with the scenarios, so you can look at bolting different interventions on and see how far it's got by different times, which is useful. You can then go slightly further and say, okay, the vaccine for smallpox isn't 100% safe. There's a life-threatening adverse event rate because it's quite an old vaccine. And so if you mass vaccinated everyone in the country, that would be quite expensive, but if it's got a 1 in 10 million case fatality adverse event rate, then you would start to see about 60 or so contraindication, adverse events to the vaccine. Whereas if you're just doing case isolation and sort of a contact tracing based vaccination strategy, you're probably going to see an outbreak of that sort of size. So you're likely to kill more people with the response than you are with the disease, given you've got very good disease controls going on elsewhere. As long as you trust those other interventions, you don't need to do this sort of knee-jerk mass vaccination campaign. And so we're able to sort of show the benefit of a more rational, sort of layered district vaccination campaign to that. So so that's sort of an example of our contingency planning. Looking at our sort of fundamental understanding gaps, if you like, we have population movement. Now, other speakers have spoken about this before. This is a paper I worked on with Matt Keeling's group at Warwick, where we used some data from a GIS consultancy company who had developed a model based on retail. They sold their sort of product to shops so they could work out the catchment of shops with similar techniques probably to that discussed by previous speakers. They had this sort of social, sort of gender and age breakdown and employment status breakdown as well. So it's quite a rich data set. And it seemed to show promise to work out the source of Legionnaire's disease outbreaks. But that was a sort of commercial product, and they didn't want to be signed up to us continually having that data moving forward. So we can't use that operationally because the data is locked in time. But looking at that, we're starting to look at ideas around social media, looking at it from a spatial point of view rather than a detection point of view, outbreak detection, whether we can look at the spatial movement of people using social media. We thought a bit about the travel sensor, APNR, or but we are with Imperial under a different HPRU fund. We are looking at mobile phones, trying to look. We've currently gone through the ethics of accessing cases, mobile phone records. All we need now is some access to that mobile phone data so that we can start to develop algorithms, because we don't know at the moment what format that mobile phone data will look like, so we can't really develop an algorithm. We can guess what that algorithm is, but it depends on whether it's GPS or whether it's cell tower locations. There's a lot of if, buts and maybes with that. So once we physically get some data, we'll be able to develop the algorithms for that. So population movement is definitely one of our sort of ongoing research questions, and so if people have interesting data sets they think would be applicable, then I'm very happy to have a conversation with them about that. The eco-epidemiology side of things, there are two questions really. It's disease persistence. So what might be the drivers? So if we had a novel infiltration of a new type of tick that carried a particular disease, what are the drivers of that establishment? And it might be climate, or otherwise, there might be other factors, overwintering, potential egg laying behaviour, all sorts of things. But we also need to look at species distribution modelling. Now this is currently sort of a sort of modelling zeitgeist, I guess, because of Zika. There's a lot of work in this area. Simon Hayes' group in University of Washington, and indeed Andy Tatum at Southampton. So we, but PHE has sort of a toolbox of models for looking at those sorts of questions, using sort of support vector machines or machine learning, as well as more classic regression models, or tools that are more within my comfort zone than as a mathematician. Looking at the dose response question, so bear with me a little bit for the network application here, but there's you have some bacteria hanging around in the environment, just wanting to infect you, and they pass over people, and for some reason one person is healthy at the end of that and one person is unhealthy. Is that statistical bad luck, or is there some? Can you come up with a model to look at what drives that output? Can you predict that? And there's been a number of trials in the 50s. People tried probit analysis, which probably works well if it's a chemical, but it's probably less good for a bacteria, where each little organism is its own little thing. So then that naturally leads into sort of independent action. When you work through the algebra there, if you rely on a single hit model, you actually just get the CDF of an exponential, so it's not particularly complicated. But you can add layers of complexity to that function by making assumptions about host variation, the distribution in a population, and the distribution of the bacteria in the cloud, and so on and so forth. Or you can develop a mechanistic model, a sort of birth-death type model, or variants thereof. So if you do that, people ingest some, inhale some bacteria. That bacteria is killed by your immune system, or it isn't. Something goes wrong with your immune system, and that bacteria replicates. You can turn that into a Markov process. This is a sort of toy illustration. It's like that, but the parameterization when you put it in is, I think the number that are born is about 300 rather than 3. So it's actually means it's much more sort of deterministic than once you've got past that initial small dose. But yeah, you can solve this deterministically, or you can solve it stochastically. And you can fit this to, this is an agent, a bacteria, Tularensis, that has about a 30% case fatality rate. It's on the CDC category A list, so it's something that the US are worried about. And you can fit various models to the human challenge data, because in the 50s, 60s, there were less ethics around challenging humans with severe infectious agents, and you can, depending on the assumptions you make in your model, you get different infectious doses. And so if you use our recent model, you get a higher infectious dose than some of the simpler models do. And we think because we've taken into account some of the mechanistic aspects, it's probably a better model, but there is the model parsimony argument that can't be ignored, I guess. That's fine. So to sort of wrap up, we have 4 sort of fairly large projects on the go at the moment, with postdocs supporting them. We've got the Emergency Preparedness and Response HPRU. We're working on a research theme there, which which is enhancing our reverse epi modelling, which is in collaboration with Paul Hunter at the University of East Anglia, or his group there. The modelling methodology, HPRU, is a collaboration with Neil Ferguson's group at Imperial, and that's the project that's looking at mobile phones and also looking at electronic data capture. So can we speed things up by sort of the data flow to us as modelers by getting people to capture the data once electronically rather than do it on a paper and then enter it more traditionally. The Impress project, FP7 funded, is our contribution to that is we've ended up using Dirichlet processes, which is a kind of variant of geoprofiling, which was used, it has been used in the sort of criminal area before. From a geoprofiling for an infectious disease is bacteria don't behave quite like criminals, so we had to put a different kernel on that. So yeah, we've enhanced it to move to this Dirichlet process to look at source term estimation, and that basically can cluster cases together in space and time, and it can allow for multiple outbreaks rather than just the assumption of a single outbreak. And then PandHub is looking at the risk of infection or transmission of disease on in transport hubs, so sort of looking at the interaction of passenger flows. And I also have a couple of PhD students working on sort of international spread of disease and the epidemiology of gastrointestinal infections under other HPR. The HPRUs are kind of confusing to those that aren't initiated, so but there are a lot of them. There's about 10 of them, all serving different themes. So just to sort of finish off before the shepherd's crook comes out and hauls me off stage, we do try, and we try where possible to have evidence-based mechanistic modelling. So rather than using convenience models. And those fundamental mechanisms need to be sort of interrogated and investigated. Different scales are critical. What is the scale of mixing, or the sort of temporal aspects of that? We need to be data driven in the model development. Model validation came up earlier in a question to a previous speaker. I'll put my hands up. It's hard because we use all data is sparse for these sorts of things. So we are reliant on using that data to calibrate, fit the model. So it depends what you define validation to be as to whether we do it well or not. And quality assurance in government is increasingly important. You've probably heard about the West Coast Main Line kind of debacle. And that, even though that was a spreadsheet model, these more complicated models get lumped into that process. So some of the challenges we face day in, day out, I guess, is that often these are small numbers. We will be asked what we can say about 2 or 3 cases of Legionnaire's disease. We can say something about 2 or 3 cases of Legionnaire's disease if they've happened in a couple of days, but often these have happened over 18 months, and there's not a lot we can say when you consider the incubation period is about 10 days. If it's an emerging infection, we'll probably not know where things are going. The model chain is critical. You've got lots of complicated models building on. You've got to be careful you haven't got a house of cards, which may or may not be the case with some of the Zika work that's sort of ongoing at the moment. And increasingly those interventions, which we can sort of simply put as another compartment in our compartmental model, there are logistics about those queuing aspects, delivery aspects, human aspects that need to be characterised much better. And I think that's all I was going to say. So any questions?
From a scientific talk in today's session. So
Are you doing any work with agent-based model approaches?
The simple answer is no, but we have in the past. So we published a paper 5 years ago or so on MRSA transmission, where we were looking at one ward of a hospital. So we knew a lot of information around the healthcare worker interaction with the patients, their contamination behaviour, a lot of contextual information. So we were able to build we felt we could go for an agent-based model because we knew the information. We knew a lot of, it's a data-rich environment. For a national model of spread, it is quite hard to parameterize agent-based models. And if you can parameterize it, it's hard to understand the causative behavior of fiddling with a number at one end and getting something out at the other. So I'm not opposed to agent-based modeling, but it's often easier to go for something simpler that you can understand the cause and effect on. But yeah, it's not philosophical design.
For species distribution modelling, how are you finding the machine learning sort of approaches as compared to the traditional regression?
It's difficult. Whilst I'm responsible for that work, I'm not the technical developer of that work, so I probably can't answer that specifically. But I think the whole point of having a sort of toolbox of those models is that you can understand, rather than have one model and rely on that, and it's sort of bang or bust really if the model is flawed. If you have 3 or 4 different model paradigms answering the same problem, then if one is struggling to fit or is doing something quirky, then you can use your judgment on that. And we'll probably look at that a bit more in the coming years, how different models in a modelling sort of answer can feed into one another. Yeah. So yeah, it's a bit of a woolly answer, but yeah, it is a sort of area of sort of current research really.
Any final questions?
Otherwise, let's thank Ian again.